Good afternoon. My name is Lisa Halpern, and I am the Vice President of Marketing at Vapotherm. We thank you for joining us at this live webinar presentation on high-flow therapy in the NICU, clinical and economic effectiveness. Our presenter this afternoon is Dr. Michael McQueen, the Medical Director of the Neonatal ICUs at Banner, Delhi Webb, Estrella, and Thunderbird Medical Centers. He has been using high-flow therapy in the NICU for over 8 years and has collected and analyzed data on both the clinical outcomes for neonatal patients and the financial implications for hospitals. It now gives me great pleasure to introduce Dr. McQueen.
Thank you, Lisa. I appreciate it, and thank you to everyone who has taken time from their busy schedules to sign in this afternoon. It's my sincere hope that you'll find this worth your time and worthwhile. And again, the format is that we will try to leave time at the end of this for a question and answer session. So to dive right in, I do want to start with a disclosure. I am a consultant for Vapotherm Inc., and I serve on the company's advisory board. Our objectives today are really threefold. First, and perhaps most importantly in my mind, is to review the mechanism of action of high-flow nasal cannula therapy. Secondly, we will review just briefly some selected clinical respiratory outcomes from one community NICU benchmarked against Vermont-Oxford network data. And third, I will illustrate some potential cost-saving impacts and cost-saving mechanisms of implementing Vapotherm high-flow therapy in your NICUs. So to jump right in, to start with the mechanism, I want to start by telling you that the three most important facts you need to know about Vapotherm and its mechanism of action are: one, it is not a CPAP device. It is not licensed as a CPAP device. It is not registered nor approved by the FDA as a CPAP device. It is not a CPAP device. Number two, its mechanism of action is not through the generation of CPAP. And number three, used correctly, and we'll elaborate on this, used correctly, it will generate little to no continuous positive airway pressure. I can tell you without a doubt the most common misperception about Vapotherm high-flow therapy that I hear is that it is a CPAP device. There are folks who are spending some good time warning colleagues about the dangers of using a CPAP device without knowing how much CPAP you are generating. I wholeheartedly agree with that sentiment. It is not a good idea to use CPAP without knowing how much CPAP you're generating. There are people who are spending time with esophageal pressure transducers measuring how much pressure can be generated through increasing flows in a sealed system. It's straightforward. In a sealed system, increased flow will generate higher pressures. This is not designed as a CPAP device. It's not designed to be a sealed system, and we're going to get a little bit into the mechanisms of action. Just to be clear, the FDA device clearance for the most current model of Vapotherm, the Vapotherm Provision Flow, is the FDA number that you see in front of you, which says verbatim, it's intended to be used for adding warm moisture to breathing gases from an external source for administration to a neonate, infant, pediatric, or adult patients in the hospital, subacute, and home settings. It adds heat and moisture to a blended medical air-oxygen mix and assures the integrity of the precise air-oxygen mixture via an integral oxygen analyzer. The flow rates may be from 1 to 40 liters per minute via nasal cannula. In the neonatal population specifically, used correctly means the following. The temperatures typically are between 34 and 37 degrees centigrade. There's some flow variation for those temperatures. At higher flows, the higher temperatures, 36 to 37 degrees, are more common. At lower flows, and by that I mean 4 liters or less, are probably 34 to 36 degrees centigrade. Flow rates are 1 to 8 liters per minute in our neonates, and that's true even for tiny babies. Our 1,000-gram babies and less than 1,000-gram babies are sometimes on flows of 7 to 8 liters per minute. Significantly, for support of the infant with acute respiratory illness, the mechanism of action actually requires these supraphysiologic flows, again, typically 5 to 8 liters per minute. Most important of all, the take-home from this mechanism of action is the recommended ratio of the nasal cannula to the patient's nares diameter be approximately 0.5. A picture speaks a lot more than the words. Hopefully you're getting a good picture of this infant on your screen. The nasal cannula, as you can see, is occluding no more than half the nares. That's absolutely essential. The patient's mouth is open. That's not a problem. In fact, it's arguably desirable. The baby has an OG tube in to help vent air, which may inadvertently go to the stomach. Here's the reference for some of the relationships between flow rates, cannula size, and nares diameters on airway pressures which are generated. It's an in vitro study published by Sivieri and colleagues in pediatric pulmonology in July of last year. They state in their study that the delivered pressures are directly related to the ratio of cannula and nares dimension. That's actually one of the most, if not the most important variable. Specifically, and relevant to our discussion, they showed limited and decreasing pressure deliveries at nasal cannula to nares ratios less than 0.8. And it is for this reason that Vapotherm uses a small caliber nasal prong size and actually recommends a nasal cannula to nares ratio much smaller than that of 0.5. This optimal nasal cannula to nares ratio allows for free egress of flow from the system. Again, it is absolutely not a closed system. And this free egress is critical to avoid inadvertent pressure generation. This also hints at the mechanisms of action that are at work in Vapotherm high-flow therapy. The actual mechanisms are probably multiple, but three of the most significant seem to be insufflation, that is the high flow itself. These supraphysiologic flows purge end expiratory CO2 from the upper respiratory tract dead space. Secondly, ventilation efficiency, and this improved ventilation efficiency comes from both decreasing anatomical dead space and from improving alveolar ventilation, and I'll elaborate more on that in just a minute. And third, decreased work of breathing from multiple mechanisms which you see there, decreased inspiratory resistance, decreased energy cost of the inspired gas conditioning, and a reduction in functional dead space volume. First, just a quick review of the anatomical dead space that we're speaking about. Approximately 30% of each inspired tidal volume is estimated to be lost to this dead space, broken into the upper respiratory tract, specifically the nasopharynx and the oropharynx, and the lower respiratory tract, the trachea, mainstem bronchi, and first-generation bronchi, not involved in gas exchange. Further, at the start of each inspiration, this dead space is filled with end expiratory CO2 remaining from the previous expiration. And both this dead space volume in and of itself and the end expiry gas composition do impact breathing efficiency and ventilation. To elaborate on the first mechanism, the CO2 washout, and specifically end expiratory CO2 washout, by supplying flows that exceed neonatal patient physiologic demand, and again, we're talking the higher end flows, 5 to 8 liters per minute, even in tiny babies. High flow nasal therapy results in a purge of end expiratory CO2 left in the upper airway dead space from the previous expiration. Similarly, the ventilation efficiency is improved by decreasing the dead space in and of itself. As an analogy, I'm taking a shot at trimming an ET tube that is too long. All of us have experienced seeing a long ET tube coming out of a tiny baby and asking for that mechanical dead space to be decreased by cutting the tube shorter. The analogy is that now the variation is that with high flow therapy, the end expiratory purge eliminates the CO2, but it also functionally decreases that anatomical dead space. If the nasopharynx and the oropharynx are turned into a reservoir of warmed and humidified air, the breath actually bypasses this much dead space, the upper respiratory tract worth dead space, and arguably the breath starts here at the epiglottis instead of here at the nares. Perhaps the mechanism that makes the most sense to me is actually that of improved alveolar ventilation. This is incredibly simple. It's basic physiology, but that makes it no less important. Remember that minute ventilation is defined as tidal volume times respiratory rate, and that alveolar ventilation, the metric that we want to look at for actual gas exchange, is that same formula corrected for the dead space. The alveolar ventilation specifically being tidal volume minus dead space times the respiratory rate equals the alveolar ventilation. By mathematical definition, any reduction in this functional dead space means that for any given minute ventilation, there is improved alveolar ventilation. But you can also look at it from the perspective of keeping alveolar ventilation constant. Assume that the infant with respiratory disease has achieved adequate alveolar ventilation, albeit with tachypnea and labored respirations, and now apply the high flow therapy to decreasing that dead space and purging the end expiratory CO2. This means that when the dead space is reduced, for any given adequate alveolar ventilation already in place, it can now be achieved with a smaller tidal volume, a decreased respiratory rate, or both. This is readily apparent clinically. It's actually what we see when we put our tiny babies with respiratory disease on high-flow therapy. Within just a few minutes, we actually see them slow their respiratory rate, breathe less labor, taking smaller tidal volumes, and having fewer retractions. This clinical assessment is actually the key to establishing the initial flow rates. We titrate it based on clinical inspection and exam of the infant, and subsequent weaning of the flow rates is also done on a clinical basis. Mechanisms for the decreased work of breathing include then this reduction in the functional dead space volume, but also the mechanisms of decreased inspiratory resistance from warmed and humidified gas. And there are data that show that warmed and humidified gas leads to decreased airway resistance compared to cooler and drier air. And there is also a presumed energy cost from the infant not having to condition that air himself. I don't know how to quantify that, to be honest. There is some energy cost to the process of gas conditioning, and that energy cost of warming the air to the ambient, to the body temperature of 37 degrees and vaporizing it to near 100% humidity, regardless of the external temperature, carries some cost, and that energy cost is alleviated when the gas is preconditioned, so to speak, delivered at body temperature and saturation. Well, let me move again just to some brief outcomes of one, excuse me, one community NICU which has been using Vapotherm high-flow therapy for approximately 8 years. This is 2 years combined data from 2009 and 2010, and it takes into account just the very low birth weight subsets in our respiratory outcomes. This is a level 3A NICU by AAP NICU definition, and over the 2 years we actually had 25 very low birth weight infants admitted each year for a total of 50 patients cumulatively. The years were 2009 and 10, and you can see just some basic demographics of the very low birth weight admissions compared to the Vermont-Oxford network from 2000. Here's the actual distribution of the 25 babies by birth weight. We had, as you can see, a total of 50 patients, almost half of them between 1,000 and 1,250 grams, just about an equal number who were below 1,000 grams and above 1,250 grams. Broken down into a percentage and compared to the Vermont network reported data, there is some skewing of the Vermont network data compared to our center of tinier babies, and I just want to note that up front. It is perhaps that they saw a greater percentage of smaller babies that could be responsible for some of the data that you're about to see, but the numbers are what they are. Again, recognizing kind of the small n from this facility. Here's the gestational age distribution of those patients compared to the network, and again, the same relative comparison comments are noted. From the combined 2 years data in this level 3 NICU, level 3A NICU, 72% of our patients, of our very low birth weight patients, required zero ventilation, no ventilator days at all. Only 28% were on the ventilator. 90% of them were treated with high-flow nasal therapy. In 2 of the chronic lung disease metrics, O2 at 36 weeks and home on oxygen, you see the numbers for the NICU compared to those reported for the network for the same time period. And significantly, the pneumothorax rate was 0% actually in these 50 babies. So now to swing into some potential cost savings from the implementation of this therapy. I want to remind you that in the old days, infant cost was actually taken care of by charging the public admission to baby incubator shows. This is from the Trans-Mississippi Expo in Omaha, Nebraska in 1898. All of those were paying customers at cost to get into the expo. This is also from the late 1890s. This is from a World's Fair exhibit in Berlin. Each incubator is actually staffed with a live infant and an attendant, and visitors paid to. And it's not that old a phenomenon. Any of you who are historians of neonatal history, I'm sure, have seen this picture in various presentations before, but there was a standing incubator and premature baby exhibit established at Coney Island that ran clear through 1943. It's pretty recent history when you think about it. Well, I'm not advocating any sort of sideshow barkers or anything to save costs, but I do think there's some mechanisms where implementation of Vapotherm can have an impact on your units. I actually would also like to say before going into this that it's very difficult to pin down precise hospital costs, much less compare them across systems. I cannot pretend to quantify specific costs for any of your programs or your units, but what I will do is just share some general concepts with the idea that you can apply these concepts to your respective practices and institutions and hopefully come up with some more concrete numbers or at least estimates yourself. As you've already seen, the first item on there, there is a potential for decreased chronic lung disease and decreased HOMO2 usage. And I'd like to add a couple of other parameters now for you to consider, those being decreased ventilator days, decreased blood gas utilization, decreased chest x-rays, and even decreased transport costs. Arguably cost savings to the system, the healthcare system, not your unit, but I think it's relevant, and we'll show you, again, some data on that. There was a nice article published by Rogowski et al. In Pediatrics in 1999 that took a stab at standardizing the methodology for comparing NICU costs across 25 different NICUs from around the country. Among other things, their analysis showed two pieces of data that I want to highlight. First, that the ancillary costs comprise about 20 to 29% of NICU total costs. And secondly, the bulk of those ancillary costs, roughly 70% of them, come from these four categories that you see on the screen: pharmacy, radiology, respiratory therapy, and laboratory. Keeping those categories in mind, I will show you now some data from two of our comparative NICUs within our system. Our system, and yours probably too, has a mechanism for quantifying acuity. Ours happens to be called the case mix acuity index relative to the cost of service or cost of stay. This case mix acuity index is derived from birth weight, gestational age, nursing staffing acuity, diagnosis. There's multiple factors involved in it, but it's an attempt at again, standardizing an acuity metric. What this graph shows is that in comparing two nurseries, the nursery with the higher acuity index, that is babies who were slightly sicker, actually had a 50% decrease in their average cost of service per case in these two NICUs over the same year time. The NICU B, the one with the more acute kids, based on the system's case mix acuity index and the decreased cost of service, again from the healthcare system, was actually the unit that has been implementing high flow therapy for 8 years now, a little over 8 years. I think a big component of that cost savings was actual duration of ventilation. In that NICU, for 2010, just for example, to show some data, 95% of all admissions had no ventilator days. And remember, it was roughly 72% of even the very low birth weight babies had 0 ventilator days. What's significant is even the babies who were on the ventilator, we only had one that was on longer than 1 to 3 days and one that was on for longer than a week. The others were often less than 24 hours. That's kind of a typical profile for what we see. The most common reason for high flow therapy with Vapotherm to not be supportable is not respiratory disease, it's respiratory effort. If the baby has a diminished respiratory effort, if he's extremely premature, if he's a 23 or 24 weeker, we've not had good success in keeping those kids off the ventilators until maybe they hit 26 or 27 weeks. And a lower cost for this NICU, it was decided to implement high flow therapy, wasn't using it yet, and had the higher cost structure. Additionally, it was decided to implement that right at mid-year in 2011, so that it made a nice symmetrical break on data comparison between Q1 and Q2 in the same nursery. What this analysis shows is that during the second half of that year, that is the high flow therapy half of the year, we actually had 400 more NICU days compared to the first half of the year. And even with that, the absolute number of ventilator days decreased by over 200. And in an attempt to standardize this, when we express as a percentage, that is ventilator days as a percentage of total NICU days, there was a 7% decrease in ventilator days. Additionally, the blood gas data is there in front of you. You can see 1,280 blood gases in the first half of the year. That's all blood gases, arterial, capillary, or the occasional venous, compared to about half of that in the second half of the year. It was actually a 47% decrease. And in the lower box, we showed a similar decrease in chest X-ray utilization with a 53% decrease. And so again, the metrics for ventilator days, blood gas, and X-ray exposure were a decrease of 7%, 47%, and 53%, none of them insignificant. And again, these general concepts hopefully can be applied to your system's cost structure and fee structure to use to estimate some potential cost saving. On your screen now, you will see some transport data, and I'm switching gears just a little bit here. This is data from a community level 2 NICU, approximately 1,800 deliveries per year. Historically, in the past, this NICU, like a lot of level 2s, transported babies out who needed higher levels of respiratory care in particular. And for this unit, those numbers were 25 to 40 babies transported out per year. Just after mid-year in 2010, the decision was made to implement the high-flow therapy model in this level 2 NICU as well, and the number of transports out of that facility has plummeted. There actually is a direct correlation with the implementation of Vapotherm high-flow therapy and the decreased number of transports out. The delivery base has not changed, the admission rates have not changed, nor has the acuity profile lessened, and the number of transports out has been nearly identically replaced by the number of Vapotherm high-flow therapy cases per year. So to conclude the highlights, Vapotherm therapy is not a CPAP device. The take-home message is that the proper and optimal nasal cannula to nares ratio is 0.5. No more than 50% of the nares should be obstructed by the cannulas. The interface with the infant is remarkably user-friendly. Almost every speaker at the recent Hot Topics meeting in Washington, D.C. commented almost as an afterthought after presenting their data. And by the way, the nurses love it. By the way, the parents love it. By the way, the babies love it. And it's a true statement. These are soft, pliable nasal cannulas that interface with incredible comfort into the baby, especially compared with an ET tube or what our nurses call the pig nose CPAP cannulas, or even the nasal mask cannulas, or larger and stiffer, more occlusive prongs, which are the wrong idea for high-flow therapy. This infant is actually in transit. The picture doesn't show it all that well, but he's being lifted by his RN and placed for kangaroo care with mom, who's sitting in a rocking chair by the warmer. He's about 26 weeks and change in this picture. The babies are incredibly comfortable on it. Through the various mechanisms described, even the tiny infants are comfortable with significantly and clinically notable decreased work of breathing, supported by normal blood gases when they are spot checked, and with significant decreased exposure to radiation, and as you've seen, at least a suggestion of as good, if not better, clinical outcomes when it comes to the respiratory parameters. My contact information is here. You're welcome to use that email address for any questions. And now I'm not actually sure how we're doing on time, but we'll open it up, and if there are questions from the field, I'll do my best.
Thank you, Dr. McQueen. We'll now open the floor for questions, and we have a question from the audience, from Dr. Clayton, asking, how does a Vapotherm differ from the simple humidified high-flow cannula?
Probably a couple of answers to that. One is that the higher flows to give precise humidity and supplemental FiO2 integration. The Vapotherm's internal integrator device. I'm sorry, I'm not an engineer on this part of it at all, but is a now FDA approved mechanism for delivering those higher flows. And again, given the mechanism of action calling for flows of 5 to 8 liters per minute in the babies, we've not dared to attempt this with regular nasal cannulas. We also have confidence in the Vapotherm provided nasal cannulas that we can size down as the patient size indicates to make sure we're achieving that optimal cannula to nares ratio.
Okay, we have another question from Michael Dunn. Do you nipple feed babies on high flow?
Yeah, what a great question, and a hot topics that was asked of several speakers as well. The direct answer is yes, we do. A lot of people, I think, have correctly wondered, you know, gosh, are they going to be gulping a lot of air, or is this possible to do? By the time the babies are able to start nippling, or even trial nippling significant amounts of feeds, or even the early trials, typically our flows are weaned down to the lower flows, maybe 5 to 4 to 3 liters even. By the way, we typically bring babies off from 3, sometimes 2.5 liters. And we just haven't had a problem with it. We advance feeds through gavage on the very tiny babies, according to our advancing protocol. And sometimes we get issues with air distending the bellies, and the nurses have gotten pretty good at making sure the vent OG tube is working, and also occasionally putting a syringe on it to decompress air if it's accumulated in the belly. We've had no issues with feeding, either gavage or when the babies are ready to start nippling.
Okay, we have another question. Is there back pressure in the smallest cannula for the smaller patients?
Good question again, and I'm glad you brought that up. There is back pressure in the cannula and in the device, but not in the baby's airway. One of the things, you know, that I think we have to get used to is that this is not the same as a positive pressure ventilation circuit, wherein the patient's airway does equilibrate to the circuit pressure. Here it doesn't. It does take higher pressures to force higher flows through the small cannulas. But again, especially with the non-occluded systems, those flows are not translating to airway pressures in the babies. Again, this is not the same as a closed PPV circuit.
Another question, can you comment on any side effects with its use? For example, distended abdomen, roll out neck episodes?
Yeah, thank you for the question. We've had no increased incidence of neck with the implementation of the high flow cannula, even in the large NICU where we switched mid-year and compared the data from the first half to the second half of the year. Secondly, our incidence of neck is at, or actually a little bit below, happily, published reports for level 3 NICUs. Abdominal distension is a different matter. We absolutely do have that issue with the high flows, and I think it's probably the issue that we have to deal with the most common. And again, it's fixed usually with a simple vent tube, and sometimes active aspiration of the abdominal air contents when we have to do that.
Next question, how were the cases managed in terms of min-max flows for each weight category?
Say that one more time. Make sure I'm getting your question right.
How were the cases managed in terms of min-max flows for each weight category?
Got it. Minimum and maximum. I don't think that's actually a metric that we would use. We don't necessarily have minimum and maximum flows by weight category. Again, it's a clinical titration based on the work of breathing. Once you're comfortable that the prong fit is appropriate and that you have an open egress for the mechanisms of action discussed, we typically, even in 700 and 800 gram babies, will use flows anywhere from 6, 7, even 8 liters per minute. Dr. Kevin Ives at Radcliffe Children's Hospital in Oxford, when I spoke with him at Hot Topics and presented at a forum with him, echoed those sentiments. I hope he doesn't mind me quoting him here. I'm sure he wouldn't. 7 and 8 liters, even in their tiniest babies, was not an issue. And it's clinical titration much more than any sort of weight category-driven measurement. I will add that I have some colleagues who tell me that their concept of high-flow cannula is up to maybe 4 or 5 liters per minute, and then they haven't seen as good results with it. I think the reason for that is you do require these supraphysiologic flows to achieve the mechanisms of action discussed. And if you're going to safely use these supraphysiologic flows, again, back to the cannula-nares ratio and the open system. I hope.
The next question is, do you see more alarms at 8 liters per minute in the infant cannulas?
Do you mean alarms from the Vapotherm system? Is that the specific question?
It doesn't specify.
I'm going to assume that is the question. We have had that issue intermittently. I'm not 100% sure what we've done to resolve it, but there were a couple of instances where we turned flows to 8 liters and the unit would alarm. It's not typical, it was the exception. And I'm not sure what sort of internal corrections have been made, but we don't seem to have that issue anymore.
The next question is about the RAM cannula. How is this different, better, or and why?
Yeah, great question. And actually, we use RAM cannula and nasal ventilation pretty aggressively as well. I'll emphasize, Vapotherm is not the only tool that we use. It's one arrow in the quiver. We think it's a critically important one to keep our kids off the ventilator. But similar to my description of the kids who don't seem to be placed on Vapotherm right from day one because lack of respiratory drive, our most common failure, again, isn't from respiratory distress or work of breathing. That can happen and require intubation, but typically our most common failure is from refractory apnea. The kids just don't have a respiratory drive enough to continue using the high flow mechanism. It's pretty typical for us to switch to RAM cannula at that time. I don't know that it's better, worse, or different. The prongs in the RAM cannulas seem to fit comfortably. We seem to have good results at keeping babies off the ventilator. If Vapotherm doesn't do the trick, then the RAM cannula might. Sometimes, I don't know how to quantify that for you. You have to put them back on the ventilator, and that tool isn't going to go away in the near future either.
Feeds well into the next question of, do you give surfactant and then place infants on Vapotherm right away?
Yes.
Sorry,
Yes, we
yeah,
do.
Yes, we do. People have asked, about alveolar recruitment and establishing an adequate FRC with Vapotherm, and I think part of what we're doing is, especially on the tiny babies, 28 weeks and less, I can't say 100%, but it's pretty close probably to giving surfactant to those babies. They're intubated for the surfactant. The surfactant is bagged in. We're probably doing a pretty good job of alveolar recruitment and establishing airway volumes. When we do that, we put the prongs in place, suction the babies out, and extubate them. So it's actually a pretty typical pattern for us to do that.
The next question is, how do you wean infants?
That is a clinical assessment question, and I doubt if even within our group we'd say we have that standardized yet at all. certainly if we're convinced, either radiographically or clinically or both, that we're dealing with RDS, it's pretty typical for us to let the natural history of that is the acute 72-hour phase, go by without attempting any weans at all. Subsequent to that, we can wean anywhere from half a liter to a liter every day or every other day on tinier babies, and it's just an ongoing clinical assessment. As interesting as it sounds and as interesting as it was to us to see it, a flow turned down from 6.5 to 6 sometimes made a difference in the baby's work of breathing, and it's it doesn't take long to figure that out. Within a couple of hours, probably, if you've pushed a little too hard and as we call it, weaned too much of the work of breathing back onto the baby, and we'll put the flows back. On some of our tinier kids, they can be on high flow nasal cannula for weeks, and we may leave them at high flows for the first week or so of life, if not longer, and they can be on flows as high as 5 or 6 for the next 2 to 3 weeks until they get bigger. About now, maybe they're starting to nipple, we get to wean their flows a little bit more, but it's not atypical for us to have a 26 or 27 week baby on Vapotherm until 33, 34 weeks.
Next question. When you take x-rays when infants are on Vapotherm, are the infants hyperexpanded as we sometimes see with CPAP?
Yeah, rarely if ever. On CPAP, on the oscillator, on conventional vent support, we deal with the overdistension quite a bit, and again, we use all those tools and deal with it. Applied properly, we're not generating any distending airway pressure, and if anything, I'd argue that we probably are concerned, do we have any microatelectasis or something. Remarkably, even on those radiographs, when we question that finding, probably because of the improved alveolar efficiency, we're actually getting good blood gases on the baby, not enough to good enough to not do anything different just based on the radiograph. The infants clinically are doing great. That's supported by a blood gas measurement. And so, no, finally, to answer your question, we don't really see much overdistension, if any.
The next question is, what was the effect on VAPS ventilator versus Vapotherm?
Yeah, I think that's probably something that I thought most about trying to include in the cost savings data, because I think it's real. But we have such a low ventilator use and such a low VAP rate, happily, that it's not something that I did choose to include. We tell our infectious disease people all the time, and the answer to your question is that you have to have a V to have a VAP, and if they're not on the ventilator, that's not going to happen. We don't see even colonization typically with even the long-term weeks. We do change the prongs out every 30 days as is recommended. Do nasal suctioning and clean out. You have to pay attention to the upper pulmonary toilet, the upper airway toilet, but we just haven't had an issue with any infections from the prongs at all. And again, if you can eliminate the bulk of your ventilators, you should be able to eliminate the bulk of your VAPs.
Next question. How do you assess infants' work of breathing?
Yeah, good question. And I'm using a term clinically that I know there's probably other definitions for. As I'm using the term work of breathing, it is a clinical assessment. Are they tachypnic? Is their breathing labored? Are they having significant retractions? Are they having expiratory grunting? All the things that all of you are familiar with, as opposed to comfortable, slower, and unlabored respirations. So I'm using work of breathing in a truly clinical assessment sense.
Can you address the previous concerns about Pseudomonas infection?
I'm not sure I have any data for you to help that. I can tell you, again, in 8 years of experience and many patients treated, it's not been an issue. I'm trying to remember if we've had a Pseudomonas infection on babies who have just been on Vapotherm. And regrettably, I'm not familiar with specific data you may be referring to, so I'm probably not the best source for that answer. Apologies.
Are there any other questions? Okay. On behalf of Vapotherm, we'd like to thank you for joining us this afternoon. Thank you, Dr. McQueen, for your excellent presentation and for sharing your wisdom and experience. A recorded copy of the webinar will be available from Vapotherm within approximately 1 week. Thank you for joining us. Goodbye.